Well, thank you so much, Susan, and thanks to everybody for coming here. So believe it or not, Flower Mound, Texas is in the DFW area and actually has a flower mound. You can go and see the flowers in the springtime, and it's so beautiful. So we're going to see some slides that maybe aren't as beautiful as Nicole was talking earlier, because sometimes dentistry has some very, very cool pictures. The thing of it is, what we know about oral and dental pain is that so many times when we have these dental issues, there's also going to be pain involved. And this pain may be from the disease itself, the discomfort from periodontal disease and loose teeth, although sometimes it can be very non-painful and still extreme. Certainly if we have fractured teeth, cats and dogs with tooth resorption will show discomfort. When we see trauma from broken teeth to broken jaws, and even as we're looking at some of the chronic pain issues we can see in some of these patients, the whole key is how are we going to manage that pain? And I know you've probably been to other seminars and you probably have a pretty good handle on pain. I just like to bring in all these potential tools that we have for both operative and extraoperative pain management to make sure we make our patients as comfortable as possible. Because if they're comfortable, then they'll continue eating. And if they continue eating, then we can keep them healthier. So those are our objectives. One of the interesting things about oral and dental pain, and for anybody who's ever had a toothache, you know this can be excruciating. When we look at the nerve endings that are primarily delta and C fibers, they can take in signals, heat, cold, pressure, pain, all of the different afferent signals. The perception that the brain registers is just pain. In other words, when they do cold testing on teeth in humans, they actually take a frozen tuberculin syringe and touch it to a tooth to see if the tooth is sensitive with endodontic disease or something like that. You actually don't feel cold, it feels painful. And this, people kind of theorize that it's because having any pain in the teeth, in the mouth, can impact the health of that patient if it doesn't eat. So you want to know right away if there's a problem and you want to do something about it. So that's just an interesting factoid about dental nerves. So as we look at our different diseases, overall, because periodontal disease tends to progress slowly in some, a little bit more rapidly in others, it actually can become quite extensive without the pet showing any discomfort, and even in people. So it's called a silent disease. You can have extensive changes with minimal discomfort, and the pet, especially dogs, will still be eating, even cats, until you start getting either ulcers or loose teeth that are uncomfortable. They may not show any discomfort. The thing of it is, it's not just about discomfort in the oral cavity when we're looking at a mouth like this. And it's not just that mouth causing bacteria to get into the bloodstream to cause distant infections for systemic issues. What we're finding out more and more, especially with human data, is that the chronic inflammation in the mouth is what can impact distant organ health. So yes, could a bacteria cause endocardiosis and everything? It's going to be pretty uncommon because that bacterial stream in the bloodstream is going on a regular basis. But it's that persistent chronic inflammation that can really impact the systemic health. That's why when we get these teeth out of these patients, they feel better because they're not as toxic as they used to be. Like I said, they will be painful sometimes if we have mobile teeth, if we have dogs with ulcers, contact ulcers, or cats with stomatitis, or even after periodontal treatment when we've done root planing or flaps and things like that. So don't just think about pain during treatment if you're doing extractions, but if you're also doing some root planing or deep periodontal treatment, think about managing the pain there as well. With broken teeth, there is pain initially, like with the canine tooth on the lower picture. If the exposed pulp is painful, that's because a nerve is exposed. But once the pulp and the nerve dies, this tooth actually is no longer painful. So we might have a situation such as that broken upper fourth premolar, even though we have some gingival inflammation from that slab fracture. Once the pulp has been dead for a while, we no longer have that acute discomfort or pain. However, the apical extension of that infection that gets in and can cause issues with the bone and even cause draining tracts, that can be just uncomfortable because of the pressure there. And certainly, again, the infection is not great. Occasionally, we can get an acute exacerbation of these apical abscesses. And in people, it's called a phoenix abscess. If they get an abscess, it flares up and is not allowed to drain. This can be extremely painful, but because of the pressure in the bone. Once it's drained, they usually have immediate relief. But certainly, as we look at broken teeth, we can see teeth that have been broken in dogs for a long time, and they're still eating. They're not showing a lot of problems. Maybe if there's a rough edge or there's a slab fracture that's still there that's wiggling around, that can be uncomfortable as well. But we have to be very cognizant of looking at these teeth, even if the pet's eating well and it's a big old fat lab, because they still could have issues with broken teeth in the endodontic system, the pulp system. When we look at tooth resorption, and that's what we call it now. I know we used to go, neck lesions and cervical line lesions and FORLs, but now they're all classified just directly as tooth resorption. The most common type we see, especially in cats, is the type 2 with the odontoclastic or replacement resorption that typically starts in the root. When this bone starts changing, the odontoclast starts changing the tooth into bone, getting past the periodontal ligament, then we don't have any kind of periodontal ligament left. But as long as it's in the roots, there's typically no discomfort. And they've seen this in people as well. When we get discomfort, it's when this extension, the resorption extends into the crown. Now we've got exposure because some of the enamel and dentin is lost. And now gingival tissue grows into this. And this is where we can have that tooth chatting. This is where they can be painful. The second type, rather type 1 of tooth resorption, is inflammatory resorption, which is only about 5% of the cases I see. And that's where we have tooth resorption because there's periodontal disease and inflammation that way. But by far the most common is the odontoclastic or typical classical type 2 resorption. Certainly, if we've had traumatic injuries, there's going to be pain. We definitely need to make sure the patient is stable, but then we need to stabilize the oral cavity whenever possible. Once we know that the patient systemically is stable, that we've taken care of any acute bleeding, then we're going to be looking at either repairing or sometimes even removing portions of these fractures. The mandible in the radiograph on the lower left side, pretty decent bone there. We can fix that. But some of the avulsion fractures with incisors or smaller teeth, or have comminuted fractures, or even pathological fractures on the mandible, sometimes we'll remove that loose section and they do pretty well. We'll sometimes even see tears in the soft tissue. So we talked about periodontal disease a while back, but now I want to talk about an extension of the periodontal disease that we see that has chronic pain due to chronic ulceration, whether it's the stomatitis in cats or ulcerative stomatitis, contact stomatitis in dogs. A lot of different names for it. Little white dogs, we see it often in Maltese type dogs. As we're looking at the ulcerative buccal mucosa contacting these, the kissing lesions, we've called it cups in the past, chronic ulcerative periodontal stomatitis. Sometimes it's called chronic ulcerative stomatitis in dogs. But wherever the buccal mucosa on dogs touches the tooth surface, there's inflammation. These are all due to some type of hyperimmune response for that individual. And usually extraction is one of the few ways that can help handle this. Occasionally some medications can help. Definitely in cats, we do a lot of extractions. These are pets that will not eat. This is more than just plain periodontal disease. Then certainly if we have any kind of tumor. As we look at these tumors, so often I don't get to see them until they're quite large because they're hidden initially. And until the patient starts chewing on them or causing them to bleed, they're usually not noticed. So if it's a large tumor that's in the mouth that you're chewing on, of course it's going to be painful. If it has osseous changes, that will be painful as well. So as we look at what we're doing with these, it's not just the effect of the mass itself, but the changes can happen to the tumor can happen to the surrounding tissues, a tumor effect. In fact, I'll often go with piroxicam as my NSAID in these instead of my typical ones, just to have a little better control of that discomfort. And some believe certain types of tumors decrease their inflammation with piroxicam being used. We will also see at times a chronic pain syndrome in cats called FOPS, Feline Oral Pain Syndrome. Now, about 85% of these cases are Burmese cats. They usually have an acute phase when they're teething as young cats, kittens, but then some of these will grow out of it, not have any problem. Others will continue to have pain when they're older. This has been identified as some type of neuropathic pain disorder, and it's associated with a trigeminal nerve when it becomes hypersensitized. Any kind of dental disease or inflammation can trigger this syndrome. That's why we see it in the teething kittens, but that's why we'll also see it then if we have periodontal disease or tooth resorption. But they've also documented that these can be triggered when there's stressful situations. And these pets can be very painful. So it's something to watch for, especially if you have a Burmese that's showing some pain in the oral cavity. We might even have certain individuals that we feel have a chronic kind of pain, either really pawing at the face or grinding the teeth. And with these, we have to look at a combination of things. Certainly, especially if there's been any periodontal disease or extractions or surgery, could there be some kind of neuropathy? Could it be osteoarthritis with the TMJ joints or dysplasia? Also check the neck and the ears, because that could be painful. And as they're trying to rub against the neck and ears, they're actually rubbing against the mouth as well. We'll also have some, particularly if we've done a lot of extractions, if we don't keep the hair trimmed around the mouth, it gets caught in those spaces that the teeth used to be, and almost becomes an OCD type syndrome with these patients. So watch for that as well. So when we get our patients in, we're going to do the full analgesic pain management with our surgical procedures. We're going to be looking at analgesic protocols. We're going to see if it's appropriate. Can we use NSAIDs? Can we use Serenia? We're certainly going to be sedating them to reduce their anxiety and looking at pain medication there. We're going to be using our preoperatives. I like using a combination of low-dose opioid with midazolam. We're going to use NSAIDs when we can. I'm going to use microdoses of alpha-2s when I can, and then we're adding Serenia in many of our cases as well. So preoperative, usually going with a combination of a sedative and tranquilizer, and we'll usually grab for some of those morphine type drugs. So as we're looking at the drugs that are useful, while buprenorphine does give us a fairly decent time span, it doesn't provide much sedation. Butorphanol sedates a lot, but doesn't last very long with analgesia. So in our practice, we'll use a low dose of hydromorphone to help start that pain medication early on, helps provide a little bit of sedation there. And then certainly these drugs can also be used in CRIs during our procedure itself. We're going to look at use our non-steroidal anti-inflammatories. If we have healthy patients with good renal function and we're not concerned about the hypovolemia or hypotension that often occurs during surgery, no matter how good you are at doing fluids and monitoring, then I'll use it preoperatively. Unfortunately, a lot of my patients are older, smaller dogs and cats, often with some renal concerns. So I will tend to wait to use that till after they've recovery, or if they're severe, I might have to avoid them altogether. We have an IBD heart patient coming in next week that's on steroids, so we're going to have to come up with some other options for him. With the tumors, remember I mentioned piroxicam, and I might have to switch off Rimadyl if they've been on that, do a little bit of washout, and anything under about 70 pounds in a dog, you'll have to get this compounded because 10 milligram is the smallest human dose you can find. But I will often go with that 0.3 mg per kg for tumors post-operatively in these dogs. Preoperatively, if their stomachs are okay and the kidney function is okay, but definitely post-operatively. The thing of it is, as I look at my perioperative pain management with my blocks, I want to get these NSAIDs started that evening, if at all possible, before the blocks start wearing off. Don't wait till the next day. Now, alpha-2 agonist, primarily dexdomitor, provides both analgesia and sedation. And with a really low dose, we can use this on a good number of our patients. But the ones that I'll take care with is I won't use it with my cardiac issue pets. With my older patients, if they're fairly calm, I'll tend to back off of this a little bit or use really small doses. The key is if I have any concerns about heart rate, blood pressure, anything, you can reverse it, which is one of the good things about the alpha-2s. If we have one of those that we've used it or haven't used it, or we've used it and reversed it, and they wake up doing the gator roll or really having problems in between, then I'll go with those really tiny doses just to help smooth it out. And we use it a lot. If you ever have a chance on YouTube, there's some clinic, I think it's in the Northeast, that did a dexdomitor remix that is really fun to watch. So look it up sometime. So with Serenity or Maropitant, we know we've been using it for anti-nausea. We've been using it for vehicle, car sickness, things like that. As we're looking at using it, we're trying to implement it preoperatively when we can. I know it stings a little bit. For a while there, we were having a little bit of trouble getting it. I think it was just an individual ordering issue. We've got plenty now. But whenever we can use these preoperative for nausea, pain, any of these things, if I can decrease how much inhalant doses I can use, I'm using it in my patients. So that includes doing perioperative regional blocks. And I mean, whether it's extractions, trauma repairs, taking out parts of jaw, or even just doing some perio treatment, please utilize your blocks. If you're good at your regional blocks, terrific. If you're not, at least do some soft tissue splashes, so to speak, get it in the mucosa above that attached gingiva. Just watch your total dose in small dogs and cats. You can go over what they need. If you have a really small cat with lots of teeth you have to take out, then you might have to dilute it. So when we look at these local blocks or regional blocks, not only does it inhibit the transmission, but it even works on the transduction along that pain pathway. We get a more comfortable patient. We need less general anesthetic. They have a smoother recovery and better healing period. In fact, we really try to look at using a longer acting local anesthesia product to help maintain that smoother transition as they're recovering and even for a couple days later. My typical go-to is I like using the Marcaine with 1 to 200,000 epinephrine. 1 mg per kg on cats. I'll go up to 2 mg per kg on dogs, but I do watch my cats. 11-pound, 5-kilogram cat, that would be 1 cc of the 0.5. I prefer it with epi as long as I don't have an arrhythmia or any other cardiac issue or hyperthyroid, because as I'm placing that block, The regional block, it's going to last longer because it stays in the tissues better. And even if I do a little block around the surgical site itself, it's going to help decrease bleeding. Now, yes, lidocaine works quicker, but it doesn't last as long. And basically, they've shown that mixing the two doesn't necessarily get you the good of both. It actually decreases how much the Marcaine works. So just get your Marcaine in a little bit earlier, maybe 5 to 10 minutes before you're doing your procedure. Good time getting your x-rays, getting your blocks done, and then going to your surgical procedures. Now, what we've been using a little bit more lately, both for the fact that it's harder to find my Marcaine with epi, and also because it's come down into a 10 ml vial, is using the Nocita, which is a bupivacaine liposomal injectable suspension. And these doses, as you see here, the 5.3 and the 10.6 mg per kg, that's not that you're giving that entire dose at the same time. It's because the liposomes gradually release the bupivacaine. So basically, it's about the same amount. So on that 11-pound cat, it would be about that 1 cc or less. The other thing we'll do to enhance the time of analgesia is adding buprenorphine to our bupivacaine. I'll go about 1 part buprenorphine, 9 parts bupivacaine. So say I've drawn up my 0.1 cc buprenorphine, I'll sterilely squirt in my 0.9 cc's bupivacaine, and that can help extend the analgesia as well. So I've liked those two combinations. Keep them as comfortable as long as possible. When we look at our different type of blocks, there are some good regional blocks. I think I'm seeing more and more people using them effectively. It does take some training, and a little typo here, but Skulls Unlimited International, buy some skulls. Have them around so you can see where you need to be doing your blocks, so you can see about roots. I use it when I'm showing owners how much I have to take off when I'm doing that tumor removal. I just love getting those blocks. Just don't type in skulls and hit search. There's interesting people on the internet. You can also do local infiltration. You can use intra-operative soaker hoses. Anything that gets it around the nerve. So I remember hearing from one anesthesiologist having the blocks talk about being perineural. Well, yeah, it's going to be around a nerve. It makes sense. So your infraorbital block, I think we've all been taught or learned about. You palpate the rostral aspect of that infraorbital canal, and you don't want to put your needle in that canal any further than the medial canthus, and you don't want to hit any important items such as the nerve or going into the artery or vein. That's why we secure the hub and make sure that we aspirate. If you can get it all the way back to where that medial canthus is, you're getting close to the pterygopalatine fossa, and this will get most of the teeth from the upper fourth premolar forward. Some people will also use a small catheter in this area to do this block. You've got to be careful not to damage anything. And the thing is, on a normally shaped dog, that's a pretty good area to go to. But what about a brachycephalic or a cat? That infraorbital canal is very short, and that eyeball, that globe, is right there. So you've got to be very careful. The other thing is, if you just put it at the rostral aspect, even with a little bit of pressure and holding your finger there, you're still pretty much just going to get soft tissue rostral to that infraorbital canal if you don't get the material in deeper. So there's been a description of a caudal maxillary block, or maxillary block with a caudal approach. At this point, you go behind that last molar, directed up, and you're getting to that pterygoid fossa where you can see those openings. But again, your globe is also there. So there have been incidences of having that eyeball injected. So be very careful. I have a clue for that. I do something a little bit differently. I actually come from the caudal aspect of the zygomatic arch. I keep my needle and syringe parallel to the palatal bone, and I aim towards the opposite nostril. That way, I'm directing my needle right to that pterygoid fossa, pterygopalatine fossa. I'm below the eye. And as I infiltrate, as I come back, I'm now going to be getting the innervation to those molars as well. So I like this caudal approach to the maxillary block. Again, having a couple of skulls around can help you practice. I'd say a dog, a cat, and a brachycephalic dog, because they are not normal. Another block is the mental block at the middle mental foramina, and placing material superficially here will get the soft tissue forward. If you get a little bit of infiltration, the canine apex is close to that area, and inside that foramen, the tissue, the bone is a little bit more porous. In fact, in larger dogs, I can sometimes get a small needle just inside that canal and slowly infiltrate. But we know that the total blocking of that area can be quite variable. And you can also have innervation for the incisors from the opposite side. So that's why we might go with a caudomandibular approach, either intraoral when we palpate the last molar and trying to get the needle right on the lingual aspect of the mandible, or from outside to make sure that we keep it placed, the needle placed just inside the mandible, and getting the material placed right at the caudal aspect of that mandibular canal. Now, this should impact the entire mandible from that point forward.
So he started grounding.
But if you do a larger volume, it could also impact the lingual nerve. So watch your volumes back there. I think if you stay in a reasonable amount, you're not going to have that issue with them chewing on the tongue if you do a reasonable amount and monitor them closely. So there's our distal aspect halfway between.
Apologies, everyone. We thank you for your patience. Hopefully her internet will come back shortly so we can resume.
Okay, can you hear me now?
Yes, we sure can, Heidi.
Okay, where did it stop?
So this isn't really, okay, so this isn't new.
I guess I'm not on again, is that correct?
I'm sorry, I was on mute. We can hear you, we just don't see your slides.
Oh, okay. So let me see what happened there. So so let me go back to share screen. Do you know which slide was the last that they saw?
It was and forgive me, the slide where the jaw was laying on its side. You were kind of showing us the inside of the jaw there.
Okay, well, that's not too bad. We will get right back to that. Let me
While you do that, I'll ask everybody if they could also please mute their speakers. That's the slide, Heidi.
Okay.
Excellent. So we really didn't lose much. You were very quick on getting that to me. Thank you.
Yep.
Okay. So we'll continue the slideshow from here. And that's where we see the distal aspect of that mandibular canal in between the molar and the angular process. So if you're not comfortable doing a deeper regional block, or there's inflammation or any kind of issues, at least get some of the agent in the buccal, the looser buccal mucosa at the site above the attached gingiva. Okay. And once you've raised the flap or the bone is exposed, then you can go. I'm going to take off my mask. Hold on just a second. Okay, there we go. Then you can put some more in the area once the flap is exposed. So now, CRIs are excellent to use. Ketamine with fluids, ketamine with morphine, any kind of combination when you're doing some significant surgery is not a bad idea. And as we look at the different products that can be used, I'm going to share a resource with you. It's called the Veterinary Anesthesia and Analgesia Support Group. VASG.org. And this is not done by a boarded anesthesiologist, but it is a very practical resource. You can go through what medications you need to use, what DRI calculators, even changes that you need to do when you have specific diseases or specific categories.
Yeah, there's nothing in that allergy.
Okay, so post-operatively, we've already talked about our NSAIDs. Certainly I'll look at piroxicam for tumors. For cats, I tend to reach for my buprenorphine for mucosal absorption. You can also add your NSAID in there if you're comfortable. And then for our long-term and even pre-procedure for anxiety in cats, I love gabapentin. Now, gabapentin on its own is not that great as a standalone pain medication, but in combination with other pain medication, it works well. Or when I'm looking at some of our chronic pain, our wind-up pain. I'm not a big fan of tramadol. I think we have quite variable effectiveness in dogs. It's a controlled substance. I get a little anxious sending too much of that out the door. It's actually a little bit better effectiveness in cats, but it's a little more difficult to give to them.
Okay. So it's not really.
So what else can we do post-operative? And what I use the term physical therapy, so to speak, it's the things that we can do other than our absolute or pain pharmaceuticals. So you want to avoid self-trauma. If they are going to mess with the mouth, get out the cone of shame. We got to do something. If they need to be a little bit more sedate, get out the trazodone for dogs, get out the gabapentin for cats. I love trazodone and gabapentin. I also talk about using cool compresses for at least the first 24 hours. And when I do this, I talk about using a hand towel, a washcloth, getting it wet, squeezing it out and putting it in the freezer, and then taking it out to where it's soft and using that as a compress. It's a little softer than using a bag of peas. The other thing we've been using is for our post-operative protocols, we've been looking at using the CC loop. Positioning it around the head can be a little bit challenging. We've got the loop lounge that we can use for cats. And I've even had cat owners will hold it up towards the head. When we look at chronic pain, the loop will also be something I'll consider. And you can even look at some of your acupuncture or your other alternate or complementary therapies when you have that chronic pain. Okay, I don't know if I've muted. Can you respond to me?
Heidi, we can hear you just fine. I'm going to remind everybody again, because we do hear some background noise from other sources. If everyone could just remember to please mute their computer.
Some of that might be mine. I apologize.
I wasn't sure, Heidi.
Yeah.
We can hear you.
Okay, as long as you can do that. And I'm trying to cover my mic a little bit, so it's so hopefully you can understand me good enough. So.
Oh yeah,
okay.
No, you're good.
Good. So if surgery wasn't enough, if we have chronic pain, if we have ongoing inflammation, and I tell you what, I have seen more stomatitis cats that when we used to extract those caudal teeth, it would be night and day at the 2-week recheck. And a number of them are still doing very well, but I've still got a number that I'm seeing mild to moderate inflammation, and they're still a little bit uncomfortable. If I haven't already taken out the canine teeth, that might be necessary, but I certainly will recheck them in a few weeks to see if they're continuing to improve or if they're still painful. One of the important things we do with these kitty cats is recheck their weight. We need to make sure they are eating and they're maintaining weight. If we need to use nutrition, appetite stimulants, we will definitely reach for those. Absolutely. Occasionally we will have to place a feeding tube, but usually that's not too frequently. And occasionally I will get some cats that are so inflamed that I'll be honest with you, I will grab for the corticosteroids if I need to. It's important to get these cats comfortable enough to eat on a regular basis. So, a couple things we think about with our refractory stomatitis. In Wisconsin, they've gone with a protocol of using 25 to 50 milligrams per cat daily And you can get that compounded in small chews. I will certainly look at adding in gabapentin and even up to 10 milligrams per kilogram twice a day, but usually starting at a low dose and trying not to have them too sedated. In others, I may try applying 1 TDC to the gingiva and even consider the Durlactin Feline. Chronic pain with FOPs, the feline oral periodontal, with a chronic pain with your Burmese, make sure you treat all the dental issues. Try to reduce the stress, if that means environmental stresses, pheromones, gabapentin, whatever you need. The thing of it is, they found that with NSAIDs or corticosteroids, there's usually a limited effect, and as soon as they're stopped, it rebounds. What they have found is using anticonvulsant medication, and most of these cats will respond to phenobarbital if it's really severe. Certainly, since we know gabapentin was originally used as an anticonvulsant, if gabapentin at lower doses is enough for milder cases, that may be sufficient. But remember, on these cats, phenobarbital might be necessary.
What he's doing is not lucky, though.
If we have osteoarthritis with the TMJ, maybe we had a previous injury, maybe they had a luxation or a fracture. This can cause a decrease in the range of motion. It can cause arthritis in the TMJ, or even with older cats, this can happen. So if I have any concerns about open mouth locking or problems eating or grinding, then I might try to listen to these teeth when they're under anesthesia. I'll try to get some advanced imaging and really look at that area and even the retrobulbar area, because that can impact TMJ range of motion. Just as a point, another little factoid for you here, those are actually sewing buttons on this kitty cat. She had a luxation of her TMJ as a fairly young cat. We reduced the luxation, but to keep it in place to where she would not open up her mouth wide and reluxate it, we actually use sewing buttons. One on each side, right and left maxillary, one mandibular, and then we connect these buttons with a heavy suture material that actually go underneath the skin. You might be able to see a little bit of that string, that little bit of suture behind the canine teeth. This allows them to open the mouth, but also close it completely, so that way they maintain some movement without moving them too extreme. So I've mentioned gabapentin before, and I tell you what, anytime I think we're going to be looking at any kind of chronic pain, wind-up pain, that maladaptive level of pain, we'll certainly go with multimodal. NSAIDs to help with inflammation whenever possible, whether it's a dog that can use it daily or a cat that we have to go with an alternate every other day or every third day, and then add in the gabapentin. We've actually worked up a little Excel spreadsheet that shows the owner to start slowly, and usually starting at night in case they get sleepy, slowly increase that dose up to 10 milligrams per kg twice a day. But you don't stop this abruptly if you're using it for pain. And you have to watch it because it's becoming a scheduled drug in some states. This is not quite the same thing as our prior to visit for kitty cats. For kitty cats, I've heard some people that have used up to 300 milligrams on a cat when they were really anxious. I know my cats do much better with about 50 to 100 milligrams. Also, with chronic pain management, we need to go back to that physical treatment, physical therapy type aspect. We need to find out what will be applicable for this patient using complementary alternative methods. Acupuncture may be part of that. There's also now some good studies with a targeted pulsed electromagnetic field, the Assisi device, the loop, that has surgeries with post-surgical and osteoarthritis. The thing of it is, as you look at the loop, this field is delivered out from the loop that can enhance nitric oxide production. That can help increase blood flow. It can help modulate cytokine and growth factors. So as we look at this decrease in pain and edema, increased blood flow, we can have increased tissue repair, more effective tissue repair with decreased pain. So the technology behind this is that there's a coil which creates a field. And as you look at how this field extends out from the loop, the area treated needs to be in this field. We usually look at about twice a day, 15-minute treatment. When you press the button, it starts a 15-minute treatment with an automatic shutoff, typically. And when we look at the studies done, both looking at a hemolaminectomy post-operative recovery, we've got a couple different studies there. Regaining pain perception, regaining proprioception. They have lower biomarker levels and statistically significant less pain. The other study shows a reduction in opioids, an improvement in wound healing, and a faster return to function. In people, when you look at these aspects, and you look at basically they look at cost ratios of how quickly they can get people back to function. This can be an important part of their therapy. So how do we do this with PATs? It can be a little bit more challenging. With the loop lounge, we can get a total body treatment, and it can fit into the sleepy pod carriers. And I've used this in some of my stomatitis cats post-operatively. We've had some that have done well in the carrier itself. We've had others that have preferred to just lay down on the pad itself. And then we have one particular cat who's much happier when the owner just holds it up next to him on the couch. So it can be challenging in some patients, but you can be pretty, I think, imaginative. So remember, the area to be treated needs to be within that loop range. And that makes it a little bit of a challenge looking at oral patients if they're calm, and we can use it with the cone of shame or with a gentle muzzle, just being very careful. And then I've also had an owner who's been able to keep it around her cat's head, but there's also this air muzzle that was designed by a veterinarian that we use in the clinic for those cats who are kind of aggressive, not real happy about getting their arm shaved for a catheter. This can also be modified to be used for oxygen therapy and even nebulization. So there's a lot of options out there. Remember how I said we had some other issues with stomatitis? We may look at low dose doxycycline. We may look at cyclosporin, and that's when looking at modulating the inflammation that causes the pain. The inflammation that can be helped with microlactin and the duralactin products, and then the 1-TDC that can help with oral inflammation. And it's also shown some effectiveness with osteoarthritis as well. The key is, what we want to do is we want to manage pain wherever we can do it, at whatever time we can do it, before, during, after, and even for chronic cases. We're going to go with multimodal options to use whatever option we can, whether it's an NSAID, an opioid, certainly local and regional blocks, and then everything from losing weight and getting them back in shape to help with osteoarthritis, but whatever we need to do to help provide that analgesia, help give relief to these painful or uncomfortable pets. Because if there's pain, you don't have a good quality of life. And we need to keep that quality of life optimal for our patients.